Welcome back to the deep dive. Look, usually we take a topic, we tear it apart, we put it back together, and we have a good time doing it. But today feels different.
It feels heavier.
It does. It is physically heavier. I am looking at the source material we have got on the desk here. We have Miller's Anesthesia, the Bible, obviously. We have Objective Anesthesia Review, ICU Protocols, long and short cases. And honestly, I am feeling the pressure.
Good. You should be.
Oh, wow. That's comforting.
No, really.
Yeah.
Because today we aren't just exploring a topic for fun. We're role-playing a very specific high-stakes scenario. I want you to get into a headspace for me.
Okay.
You're not a podcast host today. You are a postgraduate student. You've been awake for probably 24 hours. You're wearing scrubs that have seen better days. And you're standing outside the exam hall for the MD Anesthesiology final, specifically preparing for the Gujarat University pattern.
Okay. My heart rate just went up. I can feel it.
It should. Because I am not your co-host today. I am your senior faculty mentor. And I am the one who has to make sure you don't just know this stuff, but that you can actually articulate it when an examiner, who hasn't had his coffee yet, steers you down.
Okay, Professor, I'm ready. What are we facing? What's the topic?
We are facing the physiology of the renal system, but that's too broad. That's a whole textbook.
Yeah.
We are taking a magnifying glass to the Renin-Angiotensin-Aldosterone system, RAAS, and exactly what that means for us when we have a patient on the table.
The renal system. You know, it's funny. In med school, the kidney was always that subject I kind of wanted to skip. It felt like math. All the fluid dynamics, gradients, filtration rates. It felt more like engineering than medicine,
And that is exactly why it's a high-yield topic for the exam. The examiners know students hate it. They know it's where people stumble.
So they're looking for the weak spot.
Yeah. They're looking for a solid foundation. If you look at the DNB questions source material we pulled, renal physiology is a nightmare that just keeps recurring. December 1995, regulation of kidney in acid-base balance.
Okay.
December 2003. Counter-current mechanism and renal protection strategies. Then, fast forward to December 2020.
The same thing.
The same thing. They repeat concepts because they are core, and if you don't understand the plumbing, you cannot pass the exam. It's as simple as that.
So the mission today is to take all these dense texts, Miller, Guyton, all the review books, and synthesize them into something you can actually say in a Viva without freezing up.
Precisely. It's about building a coherent story, not just memorizing facts.
All right, I've got my notebook. Where do we start? Do we just jump into anatomy, the nephron?
No, stop. That is the first mistake students make. That's the trap. They dive straight into the weeds. The loop of Henle does this. The distal convoluted tubule does that. No, you need to zoom out. Part A is the overview. If you're writing a 20-mark answer or answering the first question in a Viva, you need to frame the kidney correctly.
Okay, so how do I frame it? I mean, at its most basic, it's a filter, right? It makes pee.
If you say it makes pee in the exam, I will personally fail you.
Right, noted. Never say that.
The kidney is homeostasis central. You need to start with that concept. The kidney is the master regulator of the internal environment. Miller is very clear on this. It doesn't just clean the blood, it decides what the blood is.
It decides the composition.
It regulates volume, it regulates composition, it regulates pH. It's the ultimate gatekeeper of what stays and what goes.
So it's like the chemist of the body.
Precisely. But here is the deep dive question. Why does an anesthetist care? I mean, really care. We aren't nephrologists, so why is this front and center in our exam?
Well, I guess because we manage fluids perioperatively and blood pressure.
Go deeper. Think about the source material. Miller points out that the kidney is often the first victim in shock, the first organ to go down. And it's the primary metabolic pathway for a huge chunk of our drug cabinet.
Got drug clearance.
So if you're in a Viva and they ask about the kidney, they aren't asking about urine. They're asking, do you understand how to keep this patient alive when their blood pressure crashes? They're testing your understanding of critical illness.
I see that here in the D&B questions list. There's a question on renal protection strategies. That sounds like code for how do I not break the kidney during surgery?
That is exactly what it is. So your mental structure for any answer, write this down, is anatomy, but briefly, physiology, which has to be mechanistic, and then the most important part.
Anesthetic implications.
Anesthetic implications. Clinical relevance. If you miss the implications part, you're just a physiologist. We need you to be a clinician.
Anatomy, physiology, implications.
Got it. So let's hit part B, anatomy. And I'll be honest, when I open Miller or Guyton, the anatomy section is dense. There are a million numbers. Which ones do I actually need to memorize for the exam?
You need the wow numbers, the numbers that tell a story that set the stage for the physiology.
So wow numbers. Okay.
Let's start with the basic unit, the nephron. How many?
Yeah, there says approximately 1 million per kidney.
Correct, 1 million. But that's just a number. It's trivia. Here is the stat that matters, the one that sets up your entire argument. Tell me about the weight versus the blood flow.
Okay, this is the one that always blows my mind. The kidneys are tiny. They're about, what, 0.5% of total body weight? Less than 1%.
Tiny. Two little fists tucked away in the back.
But, and this is the crazy part, they receive 20% of the cardiac output. Some sources say up to 25%. Stop. Let that sink in for you and for anyone listening. The brain, the thing that makes you you, that thinks and feels, receives about 15%. The kidneys, these two little bean-shaped organs, get 20 to 25%. Why?
I assumed it was because they just work so hard. Like they need a ton of oxygen to function.
They do need oxygen, but do they need 20% of the entire heart's output just to stay alive? No! Think about it. Most tissues extract oxygen and send the deoxygenated blood back. The kidney is different. This huge flow isn't for nutrition, it's for function.
So it's not feeding itself, it's processing.
It's processing. It's a high-flow system because it has to filter the entire plasma volume 60 times a day. It needs the raw material.
It's like a fire hose connected to a very small, very delicate water filter.
A very delicate filter. And that brings us to oxygen consumption. Miller puts it at 7% of total body consumption. That is high. But here's the Viva trap. Is the kidney hungry because it is burning energy to stay warm? No.
It's for the pumps.
It's burning ATP to run the pumps, the sodium-potassium pumps, to move sodium against its concentration gradient. That's where the energy goes.
So the more filtering it does, the more salt it moves, the more oxygen it needs.
Yes. But now here's the anesthetic implication. This is the gold nugget. If the kidney receives 20% of the cardiac output just to function, what happens when we, the anesthetists, induce anesthesia?
We drop the blood pressure, we drop the cardiac output, almost universally.
We drop the fire hose pressure, and because the kidney is so metabolically active, asking for 7% of the body's oxygen, what happens if that flow drops even a little bit?
Supply and demand mismatch. Ischemia.
Instant vulnerability. The kidney has no reserve. Objective anesthesia review makes this point explicitly. Pre-renal hypoperfusion, which is just a fancy way of saying low blood pressure before the kidney, is a primary cause of post-operative renal failure.
So the anatomy dictates the vulnerability. You can't separate them.
You cannot. So when you are quoting that 0.5% weight, 20% output stat in your exam, you are not just showing off your memory. You are setting up the argument that the kidney is fragile and exquisitely sensitive to the hemodynamic changes we cause.
You're building a case, right?
Exactly. You're building a clinical case from first principles. Now, let's tick the box for functions. If I ask you for a checklist, and I will, what are the pillars?
Okay. Based on the notes,
Yeah.
1, excretory, getting rid of the trash. Urea, creatinine, toxins, drug metabolites.
2.
Regulation. So fluid balance, water, and electrolytes.
Yeah.
Sodium, potassium, calcium,
The big ones.
the big ones. 3,
Acid-base balance.
pause on 3, acid base. We noted this is a recurring question from 1995. We will go deep on this later, but you must mention it early in any overview answer. And 4,
Endocrine functions.
and under endocrine, you are going to underline one word in red ink.
Renin. It is the start of the RAAS. You mentioned erythropoietin, you mentioned vitamin D activation, but you emphasize renin. That tells the examiner you know where the important stuff is.
And I see here, objective anesthesia review lists secretory and excretory as keywords.
Use those words. It makes you sound professional. The kidney excretes waste and it secretes hormones. Simple, but precise.
Got it. Secretory and excretory. Okay, so that's the intro and the high-yield anatomy. Now, moving into Part C, renal physiology. This is the real meat of the sandwich.
This is where the marks are won and lost.
We've talked about flow,
Mm-hmm.
but let's talk GFR, glomerular filtration rate. I feel like I know what it is vaguely, but I need a definition that I can say without stumbling over my words.
Okay, visualize the glomerulus. It's a sieve. It's a tuft of capillaries. GFR is simply the volume of fluid filtered from those capillaries into the Bowman's capsule per unit of time, usually per minute.
Okay, volume of filtrate per minute.
But for the clinical correlation, and this is from long and short cases in anesthesiology, how do we define chronic kidney disease, or CKD, using GFR?
I have that here. It's very specific. CKD is defined as reduced kidney function, quantified by a GFR of less than 60 ml per minute. for 1.73 meters squared.
Persisting for.
For more than 3 months.
Less than 60 for more than 3 months. Memorize that chant. If you just say, the patient's kidneys are not working well, you sound like a medical student. If you quote GFR less than 60 for 3 months, you sound like a registrar who knows the guidelines.
Right, precision matters.
Yeah.
Less than 60 for 3 months. But what actually changes the GFR? Because I feel like in the OT, I am constantly worried about urine output, which is sort of a proxy for GFR.
It is a poor proxy, but it's often all we have moment to moment. Now, objective anesthesia review gives us 2 big factors relevant to us. Factor 1, the hydrostatic pressure pushing fluid through the filter.
The pressure in the hose.
Exactly. Factor 2, the health and surface area of the filter itself. What damages the filter long-term?
Hypertension. Diabetes.
The big 2. Chronic hypertension causes glomerulosclerosis, scarring. If the filter is scarred, GFR drops. That's the patient's history. But what changes the pressure today in your operating room?
My propofol. My sevoflurane. A spinal block.
Yeah.
A sudden hemorrhage.
Exactly. Sustained hypotension. If the pressure in the glomerular capillary drops, filtration slows down or it stops completely. And this is where autoregulation comes in. Miller and Guyton both talk about this. The kidney tries to fight you.
Autoregulation. This is the range, right? The kidney can maintain a constant blood flow and GFR over a range of blood pressure, something like 80 to 180 millimeters of mercury.
Roughly, yes. The efferent arteriole can dilate or constrict to keep that pressure in the glomerulus stable. But it has limits. If you, the anesthetist, drop the mean arterial pressure, the MAP below, say, 60 or 70.
Autoregulation failed.
It fails. The arteriole is already maximally dilated. It can't do anymore. The kidney's internal defenses collapse.
So that's my floor in the OT. That's my target. I need to keep the MAP above that autoregulation threshold to keep the kidneys perfused.
Precisely. That's your #1 renal protection strategy. Maintain the perfusion pressure. Now let's talk about what happens after filtration. The tubes. Tubular reabsorption.
Right. 99% of what's filtered gets reabsorbed.
Or more. And Guyton gets very technical here with transport mechanisms. Do you remember the concept of Vmax?
Vaguely. Maximum velocity. Transport maximum.
Think of it like a bus.
A bus.
A bus that transports glucose from the tubule back into the blood. There are only so many seats on the bus. That's the Vmax. If you have a normal amount of glucose in your blood, everyone who gets filtered gets a seat on the bus.
So all the glucose is reabsorbed. None ends up in the urine.
Correct. But if you are a poorly controlled diabetic and your blood glucose is, say, 400...
Then you have 500 people trying to get on a 50-seat bus.
And the bus is full. Vmax is reached. The rest of the people are left on the curb, which means glucose spills into the urine. Glycosuria.
That's a great way to visualize it. It's not a broken pump. It's just overwhelmed.
Exactly. Now, why do we care about these specific transporters? Because we hijack them with drugs. Objective anesthesia review lists diuretics as very high yield. What are diuretics?
They're drugs that sabotage the transport system. They block the reabsorption of salt and water.
They break the bus. Or they block the door. Thiazides, where do they work?
The distal convoluted tubule. They block the sodium chloride cotransporter.
Good. Furosemide. Lasix.
That's the big one. The loop of Henle. The thick ascending limb.
And what does it block?
The sodium-potassium 2 chloride pump. The NKCC2.
Excellent. Spironolactone.
That's different. It's a potassium-sparing one. It works on the collecting ducts. It's an aldosterone antagonist.
Very good. Now, the Viva question. Doctor, your patient is on chronic furosemide therapy for heart failure. What are you worried about before you put them to sleep?
Well, if I'm blocking the reabsorption of all those ions, I'm worried about electrolytes, specifically hypokalemia, maybe hypomagnesemia too.
Hypokalemia. That's the killer. You are going to check that potassium level before you even think about inducing. Because if they are dumping potassium and you induce anesthesia and maybe hyperventilate them a bit,
Potassium shifts, and you can get arrhythmias.
VFib on induction. So you see how understanding the transporter leads directly to a critical preoperative check.
Yeah, that connection is crystal clear. Okay, let's move to the thing that actually scares me. The countercurrent mechanism.
The bane of every medical student.
Seriously, I see it on the DMB questions list for both 2003 and 2020, so I absolutely cannot skip it. But visualizing the countercurrent multiplier versus the exchanger, my brain just ties itself in knots.
Let's simplify it. You don't need to be a physicist for the exam. You just need the core concept. What is the goal?
To make concentrated urine, to save water.
And how do you save water? You need to create a reason for water to leave the collecting duct. What's that reason?
Osmosis, a high salt concentration outside the duct.
Exactly. So the goal is create a salty medulla. That's it. How do you do it? The loop of Henle actively pumps salt out of the tubule into the interstitium. That's the multiplier. It makes the medulla incredibly salty.
Okay. Loop pumps salt. Medulla gets salty. Simple enough.
But here's the trickle part, the part everyone forgets. The blood supply. The vasa recta. Miller is very specific about this. They are these weird, long, dipping capillaries that follow the loop of Henle.
Right, the hairpin loops. And Guyton says the blood flow there is incredibly low, sluggish.
It has to be low. Think about it. If the blood rushed through that salty medulla at high speed, what would happen to all that salt you just worked so hard to pump out?
It would just wash it all away.
It would wash out the gradient. The whole system would fail, so the flow must be sluggish to preserve the saltiness. The vasa recta act as countercurrent exchangers, passively removing water and leaving the salt behind.
Okay, so slow flow preserves the gradient. But, and here's the deep dive question, what is the physiological downside of sluggish blood flow?
Sluggish flow means poor oxygen delivery. Bingo. The renal medulla is constantly, under normal conditions, on the verge of hypoxia. It is living in a state of physiologic suffocation just to do its job of concentrating urine.
Wow. I never thought of it that way.
So now connect that to the D&B questions about renal protection. If you have a patient in cardiac failure or septic shock or who's bleeding on the table,
Then that already low medullary perfusion drops even further. It goes from sluggish to stopped.
and the medulla dies, that's acute tubular necrosis, or ATN. It starts in the medulla.
So maintaining that perfusion pressure, that MAP of 65 or 70, isn't just about keeping the numbers up for the GFR. It is about actively pushing blood through that sluggish hypoxic swamp in the medulla so the tissue doesn't rot.
That is a graphic image, but yes, that is the core physiology. If you can explain it that way in an exam linking the anatomy of the vasa recta to the physiological risk of medullary necrosis, you are getting full marks.
Okay, that actually sticks. I can see the swamp.
Good. Now wipe your brow. We are done with the heavy plumbing. We need to talk about the chemistry set. Part D, acid-base regulation.
Right, this is the December 1995 question. Role of kidney in acid-base balance. I feel like I always rely on the lungs for acid-base. It's faster.
The lungs are the paramedics. They arrive on the scene fast, minutes. They blow off CO2. They can compensate for metabolic acidosis very quickly, but they can't fix the underlying problem.
They're a temporary fix.
They are. The kidneys. The kidneys are the surgeons. They take hours or days to really get going, but they fix the problem permanently. They play the long game.
Okay, the long game. So what can they do that the lungs can't?
The kidney does two fundamental things. One, it excretes fixed acids. We're talking sulfuric acid, phosphoric acid byproducts of protein metabolism. The lungs can't breathe those out.
Only the kidney can get rid of them.
Only the kidney. And two, and this is the really clever bit, it generates new bicarbonate.
So it's not just reabsorbing what's already there,
Yeah.
it's actually manufacturing fresh buffer.
Correct. It does this through the excretion of hydrogen ions, which are buffered in the urine by phosphate and ammonia. Every time the kidney manages to pee out a hydrogen ion, it sends a brand new, shiny bicarbonate ion back into the blood.
Okay, let's role play a scenario. I have a patient in the ICU. They have a metabolic acidosis. The pH is 7.2.
Okay.
I look at the arterial blood gas. If I see that the bicarbonate is low, that tells me the buffer is being used up to fight the acid.
Right. And objective anesthesia review suggests using the ABG to pinpoint the cause. If the kidney is working properly, what should it be doing in response to this acidosis?
You should be kicking out acid and making new bicarb. So I should see the bicarb levels start to rise over the next day or two.
Exactly. But if the bicarb stays low, or if the kidney is the cause of the acidosis, like in renal tubular acidosis, then you have a renal failure problem compounding your critical illness problem.
And the anesthetic relevance there. Why do I care so much about a pH of 7.2?
If your patient is acidotic, your drugs don't work as well. Simple as that. Your catecholamines, your norepinephrine, your epinephrine, they work very poorly in an acidotic environment. Myocardial contractility drops. The patient becomes resistant to your resuscitation.
So preserving renal function is actually preserving my ability to resuscitate the patient from shock.
Now you're thinking like a clinician.
Okay, I'm ready, I think. We have skirted around the edges, but now we have to dive into the center of the storm. Part E. The Renin-Angiotensin-Aldosterone system, RAAS.
This is part E in our discussion, but in
Yeah.
your mind, this should be part A, B, and C. This is the system that keeps your patient alive when you cut them, when they bleed, when their pressure drops.
Miller references the Miranda and Grissom paper here. This isn't just academic physiology, this is a survival system.
Let's strip it down to its core. What is the RAAS? in one sentence.
It's a hormonal cascade that regulates blood pressure and fluid balance.
Good. Now, what turns it on? This is the most critical question for an anesthetist. What is the trigger? There are three main ones.
Okay. Renin comes from the JGA, the Juxtaglomerular apparatus, so the triggers have to be sensed there. 1, low blood pressure in the afferent arteriole, the baroreceptor function.
Correct. Perfusion pressure drops. Renin is released. 2.
2 is the macula densa. It senses low sodium chloride delivery to the distal tubule, so low salt.
Low salt, low flow. It
Yeah.
assumes that means low pressure upstream. Good. And 3, the one we control.
Sympathetic stimulation. Beta-1 receptor stimulation on the JGA cells.
Stop! Sympathetic stimulation. Translate that to the operating theater. What does that mean?
Sympathetic stimulation means pain, light anesthesia, anxiety before the case.
Exactly. Or fear. Or the surgical incision itself. The moment the surgeon cuts the skin, the sympathetic nervous system fires. That nerve signal goes directly to the kidney and says, release renin, we are under attack.
So even if their blood pressure is perfectly normal, the surgical stress itself is activating the RAAS.
Precisely. You are priming the pump before you even see a drop in pressure. Now, renin is released. It's an enzyme. It finds angiotensinogen floating around from the liver and cleaves it to make angiotensin the thirst.
And angiotensin thirst is pretty useless on its own, right?
Mostly, it has to get converted, and that's where ACE comes in, angiotensin-converting enzyme, mostly found in the lungs. It turns angiotensin into the main event.
Angiotensin II, the beast.
Tell me about angiotensin II. Why is this an exam core topic? What are its actions?
Because it does everything. It's the ultimate crisis manager. First, and most famously, it's a potent vasoconstrictor. It squeezes the arterioles to raise systemic vascular resistance and therefore blood pressure.
It's one of the most potent vasoconstrictors the body makes. What else?
Second, it goes to the adrenal cortex and stimulates aldosterone release. We'll get to that. Third, it goes to the brain, the posterior pituitary, and stimulates ADH-release antidiuretic hormone to save water.
Good.
And fourth, it also acts on the brain to create the sensation of thirst. It tells you go find water.
So look at that. It squeezes the pipes, it tells the kidney to hold on to salt and water via aldosterone, it tells the kidney to hold on to pure water via ADH, and it tells you to drink more. It is the save my life hormone.
The hemodynamic implications are huge. It increases afterload by squeezing the vessels, and it increases preload by increasing the volume.
Correct. Now let's look at the final soldier in this army, aldosterone.
Aldosterone comes from the adrenal cortex. Long and short cases emphasizes this, especially in the context of heart failure.
Yes, so angiotensin II tells the adrenal to release it.
Yeah.
Where does it work, and what does it do?
It works on the principal cells of the distal tubules and the collecting ducts. And its main job is to reabsorb sodium and, by extension, water. And in exchange, it kicks out potassium.
Sodium in, potassium out. Burn that into your brain.
Right. And the long and short cases connection, it says that in chronic heart failure, the body thinks it's in shock all the time because the cardiac output is low. The kidney perceives low perfusion.
So it cranks up the RAAS.
It cranks up the RAAS constantly, which means it's cranking up aldosterone constantly.
And the result of chronic high aldosterone.
Massive salt and water retention, peripheral edema, pulmonary edema, congestion. The RAAS, which is supposed to be a short-term survival tool, is actually making the long-term heart failure worse.
Brilliant. That is the kind of synthesis that gets you a distinction. You are connecting the renal physiology of the collecting duct all the way to the clinical pathology of congestive heart failure. That's the goal.
Okay, Professor. I feel like I understand the machine now. I can see the cogs turning. Now I need to understand what happens when I throw a big, clumsy wrench in it.
Welcome to Anesthesia, Part F Integration and Clinical Correlation. This is where we separate the students from the doctors. Section 12. RAAS in shock and anesthesia.
We've established that RAAS defends against shock, but objective anesthesia review talks about pre-renal failure, again here in this context.
Think about the tug of war. Side A, the RAAS, it's firing on all cylinders, desperately trying to vasoconstrict and maintain perfusion. Side B, you, the anesthetist. You give a bolus of propofol, you perform a spinal. What are you doing?
I am vasodilating, I'm causing a sympathectomy, I'm dropping the pressure.
You are actively fighting the RAS. Now, if the patient is hypovolemic or in shock, they are surviving only because of their maxed out RAAS and sympathetic tone. If you come in and induce anesthesia, you knock out that sympathetic tone.
So the RAAS drive drops.
Or, more accurately, the vascular tone that the RAAS was acting on completely collapses. That is why induction of anesthesia in a shock patient is one of the most dangerous things we do. You are cutting the safety line.
And that leads perfectly into Section 13, drug interactions. This is the very high-yield warning label all over it. ACE inhibitors.
I want you to listen very carefully here. This is a common Viva question and, more importantly, a common clinical disaster. Tell me about the patient taking enalapril or ramipril who comes for surgery.
Okay. Objective anesthesia review uses the phrase severe catecholamine-resistant hypotension.
Unpack that. What does it mean?
Okay, so the patient is on an ACE inhibitor. That means they cannot make angiotensin II. Their blood pressure is being maintained by other systems, but the RAAS response is blunted.
Right. The safety net is gone.
I induce anesthesia. Vasodilation happens. The blood pressure starts to drop. Normally, the body would scream, "Release renin! Make angiotensin the squeeze!" But there is no angiotensin II.
The factory is shut down, so you see the pressure drop. What do you do as the clinician?
I give a pressor. Ephedrine or phenylephrine.
And what happens?
Nothing, or very little.
Very little. That is catecholamine resistant. Why? Because the entire system that those drugs work with is uncoupled. The receptors might be downregulated. You have removed the fundamental foundation of their vascular tone.
So what do I do? The patient's pressure is 60/30?
You're in trouble. You might need to reach for something that bypasses the RAAS entirely, like vasopressin or terlipressin. But the key exam answer is about prevention. What does objective anesthesia review and general practice suggest?
Withholding the ACE inhibitor on the morning of surgery.
Exactly. Stop the drug to save the pressure. Now, it's a controversial topic in guidelines, and it varies, but for the exam, you acknowledge the significant risk of refractory hypotension.
And ARB's angiotensin receptor blockers, like losartan. I assume it's the same story.
Same mechanism, same risk. You're blocking the system at a different point, but the result is the same. No angiotensin II effect.
Okay, what about a really common drug? NSAIDs, like ibuprofen or diclofenac.
In the perioperative period,
Yeah.
Very dangerous. Lung and short cases is strict on this.
Right.
You need to understand the physiology.
Okay.
Prostaglandins, which are blocked by NSAIDs, cause vasodilation of the efferent arteriole. They help keep the door open for blood to enter the kidney. Angiotensin II, which is part of the RAAS, preferentially constricts the efferent arteriole. It keeps the door closed to build up pressure inside the glomerulus for filtration.
So under stress, prostaglandins open the front door and angiotensin II closes the back door. This maintains filtration pressure.
A perfect summary. Now, if you give NSAIDs, you block prostaglandins. What happens?
You close the front door.
And if your patient is on an ACE inhibitor, you can't make angiotensin II. So what happens at the back door?
It's wide open.
Front door closed, back door open. What happens to the pressure in the glomerulus in the middle?
It plummets. Filtration stops. Acute kidney injury.
We call it the triple whammy. A patient on a diuretic, making them volume down, an ACE inhibitor, blocking the efferent response, and then you give them an NSAID post-stop, blocking the efferent response. It is a recipe for renal failure. Avoid it.
Wow. Okay. That's a clinically vital takeaway. Moving on to Section 14, the perioperative period itself. Let's talk about the gases we use, the vol anesthetics.
Miller is clear. They all, in a dose-dependent way, decrease renal blood flow.
Because they're vasodilators and cardiac depressants. They drop cardiac output and MAP. Less pressure in, less flow to the kidney.
Yes, but there's a nuance. Miller notes that isoflurane, sevoflurane, and desflurane tend to preserve the hepatic arterial buffer response, but their renal effects are directly related to how much you turn up the dial.
And the whole fluoride issue. I feel like this is a historical trap that examiners love to bring up.
It is. It dates back to an old drug, methoxyflurane. It produced huge amounts of fluoride ions. It was a known nephrotoxin, caused a high-output renal failure.
Right. And sevoflurane also gets metabolized and produces fluoride ions. And it can also produce something called compound A.
It can, but we use sevoflurane every single day in millions of patients.
So is it actually a problem?
In rats, compound A is toxic. In humans, Miller and countless studies say clinical renal injury is extremely rare, if not entirely theoretical. However, for the exam, you need the safe answer. I would avoid low-flow sevoflurane for long durations, especially in patients with pre-existing renal dysfunction, in order to minimize the theoretical accumulation of compound A.
Okay. Acknowledge the theory, but frame it as a cautious, safe clinical practice.
Exactly. Now, Part G ICU and exam integration, we are in the home stretch. Think of this as the cleanup.
Okay. Renal failure. We defined CKD earlier.
Yeah.
Let's talk about AKI, acute kidney injury. ICU protocols divides it into pre-renal, renal, and post-renal.
Keep it simple for your first pass. Pre-renal, it's a flow issue.
Yeah.
Shock, hypotension, hemorrhage. The kidney itself is fine, it's just not getting blood.
Renal. It's a tissue issue. The kidney itself is damaged. Toxins, drugs, prolonged ischemia causing ATN.
And postrenal.
That's an obstruction. A plumbing problem after the kidney, a stone, a blocked catheter,
Yeah.
a tumor.
Good. Which is the most common cause of AKI in the perioperative setting?
Prerenal. It's almost always us causing the hypotension.
Correct. And it's the most reversible if you catch it early. Now, the most practical question you will face on the wards and in the exam, doctor, this patient is in renal failure. Their GFR is 20. How do you modify your anesthetic drugs?
Right. The dosing.
Let's do a rapid-fire drug check. Opioids. You want to give morphine for pain?
Morphine. I think you avoid it.
You avoid it. Why?
Active metabolites. Something called morphine 6-glucuronide, M6G.
And what does M6G do?
It's a potent sedative and respiratory depressant, and it's excreted by the kidney. So if the kidney fails, M6G builds up and up and up. Your patient will stop breathing in the recovery room hours after you gave the drug. So what do I use instead?
Fentanyl.
Why fentanyl?
Long and short cases says high hepatic extraction. It has no active metabolites that are excreted by the kidney. It's safe. Or even better, remifentanil.
Because it's metabolized by plasma esterases.
The kidney doesn't even enter the equation. It's completely organ independent.
Okay. Muscle relaxants. What about rocuronium? Rocuronium has some hepatic clearance, but some renal too. So its clearance is reduced. You'll get a prolonged block. You can use it, but you have to be careful and monitor the neuromuscular function.
So what is the gold standard relaxant in renal failure?
Atracurium, or cisatracurium, because of Hoffman degradation.
Explain that.
It breaks down spontaneously in the blood based on the body's pH and temperature. It doesn't need the liver or the kidney to get rid of it.
Perfect. Cisatracurium is organ independent. That is the magic phrase that tells the examiner you know exactly what you're talking about.
Got it. Okay, section 16, comparison tables. You mentioned drawing tables in the exam.
If you are running out of time in a written exam or you want to structure a complex answer, draw a table. Normal kidney versus renal failure, or prerenal AKI versus renal AKI ATN.
What would I compare?
Compare things like urine osmolality, urine sodium. In prerenal failure, the kidney is desperate to hold on to salt and water, so the urine is concentrated, and the urine sodium is very low, less than 10. In ATN, the pump is broken, the kidney can't reabsorb salt, so it wastes it. The urine sodium is high, more than 20 or 40.
Ah, that's a key differentiator.
It is. Objective Anesthesia Review has these charts. Memorize one, it saves you writing 200 words.
Okay, good tip. Section 17, common exam questions and Viva traps. We've covered the prerenal trap of ignoring hypotension and the NSAI trap. Are there any others?
There is one more big one, renal dose dopamine.
Oh, right. Using low-dose dopamine to try and increase blood flow to the kidneys and protect them.
It is a myth. It's dogma from decades ago that has been completely debunked. ICU protocols and every modern text is clear. Do not say in an exam, I will give renal dose dopamine.
What do I say instead?
You say, there is no evidence to support the use of so-called renal dose dopamine. My strategy for renal protection will focus on optimizing the patient's volume status and maintaining an adequate mean arterial perfusion pressure.
Good catch. I would have walked right into that one.
Many do. Last bit of practical advice. Section 18. Diagrams.
You want me to draw in the exam?
You must draw. A picture is worth 1,000 words, especially to a tired examiner. You need 3 diagrams in your arsenal. 1. The nephron, labeled as segments. Glomerulus, PCT, loop, DCT, collecting duct.
Okay.
2. The Juxtaglomerular apparatus, a simple drawing that shows the macula densa of the distal tubule touching the afferent arteriole. That single picture shows you understand the whole feedback loop.
Right, the physical connection.
And 3. The RAAS flowchart, a simple box and arrow diagram. Liver makes angiotensinogen, renin acts on it, angiotensin the first, ACE in the lungs, angiotensin the second, then arrows going to vessels, adrenals, brain. If you draw that flowchart clearly, the examiner barely has to read your text. They'll see you get it.
Okay, Professor. We have covered a massive amount of ground, from the 0.5% weight to the hypoxic swamp of the medulla to the catecholamine-resistant hypotension of ACE inhibitors.
We have.
Let's bring it home. Part 19. Summary and exam conclusion. If I had to summarize this for the conclusion of a 20-mark answer, what are my take-home bullet points? The absolute must-knows.
Let's do a rapid-fire summary. The very high-yield points we discussed. Are you ready?
I'm ready.
1. The kidney is a high-flow, high-demand organ, 20% of cardiac output, 7% of oxygen, making it uniquely vulnerable to ischemia.
Got it.
2. Prerenal hypoperfusion is the leading cause of perioperative acute kidney injury.
Okay.
3. Autoregulation fails below a MAP of 60 to 70 millimeters of mercury. That is your floor.
My floor.
4. The medulla is naturally hypoxic because of the vasa recta. Hypotension kills the medulla first. 5. RAAS is the primary defense against hypovolemic shock. 6. ACE inhibitors block this defense, leading to refractory hypotension under anesthesia. 7. CKD is GFR less than 60 for more than 3 months. 8. In renal failure, avoid NSAIDs and morphine. Use fentanyl and cisatracurium. And 9.
There is no such thing as renal dose dopamine.
That is a powerful list to have in your head.
It is. So how do I wrap that up in a nice paragraph for my conclusion?
Your concluding paragraph should sound something like this. In conclusion, the renal system is not merely an excretory organ, but a central regulator of hemodynamic and metabolic stability. For the anesthesiologist, a deep understanding of renal physiology, especially the Renin-Angiotensin-Aldosterone system, is critical for anticipating and managing shock and fluid balance. Perioperative renal protection is best achieved not by specific pharmacological magic bullets, but by the meticulous maintenance of adequate renal perfusion pressure and the avoidance of known nephrotoxic insults.
Not magic bullets, but perfusion pressure. I like that. It's a great summary of everything.
It is the truth. That's the job.
Thank you, Professor. This was intense, but I feel like I can actually face that stack of books now. I have a framework.
Good. The exam is hard, but it is fair. If you know the why, you can always figure out the what.
To our listeners, my fellow stressed out students out there, grab a piece of paper right now. Pause this. Draw the RAAS pathway. Draw the nephron with a JGA. Don't just listen to it. Do it. Make the memory physical.
And remember, stick to your sources. Everything we discussed today came strictly from Miller, Objective Anesthesia Review, ICU Protocols, Long and Short Cases, and Guyton. Stick to the standard texts. They will not lead you astray.
Good luck with your preparation. Go crush that exam.